All right, good morning and welcome to, I think, our final discussion on Seinfeld. We'll be discussing the red dot today, so who'd like to start? Observations, any initial thoughts?
There's a lot of, sorry.
You could go.
No, there's a lot of impulsiveness, I think, amongst like a lot of the characters, like George, and the cleaning lady, and like also the, forget his name, but the Elaine's companion, who goes to drinking. So, yeah, there's a lot of people sort of not coping with their like life stressors.
Okay, somebody comes in, makes an office appointment for you, psychiatric evaluation, whether it's a chief complaint, reason for consultation, clinically significant impulsivity. Take me through what's running through your mind.
ADHD.
So now we're looking at a short list of mental disorders for which impulsivity is either a characteristic or perhaps even a diagnostic criterion, right? So, all right, ADHD, any other thoughts?
Bipolar.
Bipolar disorder?
In this
Social.
Okay, antisocial personality?
in this context, given that it's like sexual impulsivity, you can also, I think, include things like a histrionic personality as well.
Other cluster B personalities like histrionic borderline personality?
Mm-hmm.
If they have a history of being on a dopamine agonist.
So medication-induced impulsivity, right? And that's where we have to start, right? And I want that, it's kind of tricky. It is perfectly, I think, not only, use the word normal in terms of the way we think, but it's certainly standard of care to have a short list of mental disorders. But immediately after we begin to think that way, we remind ourselves that nothing is going to be ruled in until we investigate and rule out the direct and physiologic effects of a substance in that. So think of it as 1, which is our initial thought. This might be due to a mental disorder, but 1B very quickly, and then B just somehow goes to the top. We just mess around with that alphabet, right? And for this episode, what do we see?
Well, alcohol.
Yeah, a lot of alcohol, right? And there's one character that's actually afflicted with alcohol use disorder. Right? So again, sitting and, whoops, how about that? Or falling in an office-based setting where somebody like this would present, alcohol use disorder is something that I think might be part of the initial assessment. Now, I think with this kind of information, you probably could just skip right over the cage questions. There's no reason to screen your patient at this point if you're going to go forward with a diagnostic interview, which is just a fancy way of saying you're going to review the DSM criteria for alcohol use disorder. And I think for a third-year medical student to present the cage questions and then the diagnostic criteria is fine because it's a learning experience. But in clinical practice, if you know you're going to do provide the psychiatric assessment, review those criteria, I probably don't need to know that the patient caged 1 out of 4 or 2 out of 4. By the way, in clinical practice, what is a positive screen? How many questions on the cage do we look for? Yeah, in research, it's a trick question. And I posed it, I use my words very carefully. In a clinical setting, we use 1. Right? Now, the reason why we always hear 2 is because of research. We have to have consistency across research studies. And with about an 80% sensitivity and 80% specificity, it's been arbitrarily agreed that the number of false positives and false negatives for that matter is something that we're okay with at the 80% threshold. So that's 2 out of 4 research. When we go to 1, we increase the sensitivity of that screen into the mid-90s, albeit at the expense of some false positives, right? So the specificity drops into the 70s. All that means is that you're going to then provide that diagnostic assessment, and you're going to just root out those false positives. And that's no clinician would think that would be a, quote, waste of their time, end quote. So use 1. All right. The other thing I wanted to talk about for this episode especially in the context of alcohol use disorder, is alcohol intoxication. I don't think there's any way the National Board is going to sneak a vignette by you on your shelf and you not get what somebody looks like when they're drunk. So I'm not really concerned about that. What I'm a little bit more concerned of is withdrawal. Now I think, again, after 4+ weeks of a psychiatry clerkship, the majority of which is spent on a consult service in a major hospital, I think you've seen this enough where you're set for your shelf exam. Having said that, there's a couple things I want to mention. Number one is, and it's more of a clinical pearl, the way and I don't know how many people have actually studied the DSM in the past 4 weeks, certainly with clinical experience. A lot of the information that we get for alcohol withdrawal is taught to us through the CEWA protocol, right? And the good news is that, 90+% of the CEWA protocol does overlap with the diagnostic criteria in the DSM. However, in the CEWA protocol, they do include headache. That could come up on a shelf exam, and if you are studying strictly from the DSM, you might miss that. Right? So headache does not appear in DSM criteria. Headache does appear on the CEWA protocol. Headache is a sign of alcohol withdrawal, even though the APA does not capture it in their diagnostic set. Just maybe a clinical pearl, but something to just keep in your mind for the shelf as well. Vice versa, vital signs are not part of the CEWA. They are part of the DSM criteria. Right? So just things to keep in the back of your mind. Having said that, I want to flip this to some clinical care now and the treatment, the medical management of alcohol withdrawal. If a patient comes in and you believe that they are at significant, or either they're in withdrawal or significant risk to experience withdrawal, you want to provide them benzodiazepine. You want to provide them a medication that has a very similar, if not the same, mechanism of action as the drug of abuse. In this case, it's alcohol. That's referred to as substitution therapy. One way in which you can provide substitution therapy is through the hospital-wide CEWA protocol. If you are not in a hospital that has ratified that as a policy or protocol, you'll probably go with the standard taper. You'll start the individual on a medication, a benzodiazepine, at a particular dose, at a particular schedule, and then over 24 to 48 hours, reduce that dose to safely and medically manage their alcohol withdrawal. Again, in this case, either trying to word this correctly. There are a couple of clinical situations in which, even if your hospital had ratified or does have the CEWA protocol, you may opt for that standard taper nonetheless. And this comes up for our service frequently, where the individual will be admitted, placed on the hospital protocol, and then we're consulted, and one of our recommendations is to stop or discontinue the CEWA and place the individual on the standard taper of lorazepam, for example. There's two situations in which that occurs frequently. Any guesses as to what those two situations, those two clinical scenarios are? Remembering that the CEWA protocol requires a bedside assessment. If the individual, for whatever reason, and I think one of the more common reasons is delirium, cannot participate in that clinical interview, the results of that protocol might be equivocal. And if there's any concern that it's resulting in their getting too many benzos, resulting in the benzodiazepine further inducing or perpetuating their confusion and delirium, it's probably best that the practitioner, through guidance with the consult service, take over the prescribing and the management, and it's not opted or it's not defaulted to the protocol. The other situation, which actually occurs more rarely, is the opposite, where you think the individual is coherent and is premeditated and is also giving false information, but because they want more, often referred to as quote-unquote drug seeking. That could happen. And if there's any concern that they're being provided benzodiazepines in excess of what they really need, you can opt for a standard taper.
I was just curious, I've never seen it, but in the case of someone with alcohol use withdrawal and gets benzodiazepines that cause like paradoxical agitation,
To go to the standard taper. Yeah, because the idea here is, okay, there's two things, quality and quantity. And we focus on quantity first. Maybe they're just getting too much. So it's a great idea then to have someone with experience just take over the dosing rather than opt for what the computer or the EMR would provide through a protocol. So there we revert back to the standard taper, and the idea here is that we're going to regulate the dose and get by with lesser milligrams per day, and therefore addressing the individual's confusion, the paradoxical effect. If that doesn't work, it may have been quantity, but maybe there's quality involved too, and that is that the individual is just getting the adverse reaction, which we do see, despite them being dosed correctly or perhaps even underdosed. There it gets a little bit more tricky. It's reasonable to assume that if an individual is having that paradoxical effect, oh, by the way, I should say too, we always have to consider that we're underdosing and that confusion is not a paradoxical effect, but worsening delirium because we're underdosing too. So that's going to be added to the clinical conundrum. Assuming that is not the case, it's reasonable to assume that if an individual is experiencing this through the benzodiazepine, the barbiturate is probably going to also induce that. And you could have a trial of a barb, but you got to be prepared that you're going to have a similar effect. There really are no other medications that get that type A recommendation or the type 1 recommendation beyond the benzodiazepine or sedative hypnotic class. So here we're going to go with more or medications with more of empirical evidence, but not really as well established in the clinical literature. So here we think of other medications that are GABAergic, so we want to hit the same receptor. And I would start with the anti-epileptic drugs. That's where we start.
We had a patient earlier this week, and that's why I wanted to ask kind of what this place in therapy Librium was, because the patient, I believe, was put on SIBO protocol, but he was on both diazepam and Librium. To my understanding, both are long-acting benzos, so I was kind of confused as to why he was on both.
Mistake.
Okay.
Usually, and because both are relatively inexpensive, both are absolutely at the very top of the list of drug choice. But going with a green M&M as well as a red M&M doesn't make much sense. Having said that, it still worked. Now, I'll tell you why I'm strongly biased to just go with one, and that is if you have something that is on as through a SIBO protocol as well as another that's part of basically a standard taper, right? You're doing both. Right? If you see that X number of milligrams was provided through the SIBO, which basically defaults then as a PRN, right? You have a taper, and then you have additional doses as needed, albeit through a SIBO protocol. If you have the same medication, let's say it was fluoridase epoxide or Librium, when you come in the next day, you could look at the total milligrams required through the SIBO as needed that standard taper didn't cover, and adjust the standard taper accordingly. That's a one-to-one. I mean, you're using the same drug, so that's literally fourth grade math. On the other hand, if you go with Valium, which is diazepam, you're going to have to go to a conversion chart, right, which is an extra step. Now, I mean, I don't mind it on days in which there's no intercession, because I will clearly delegate that to my medical student. And you've heard us talk about this before, albeit with the antipsychotics, right, and there's chlorpromazine equivalents. So no harm, no foul. It's just an extra step, and it doesn't really make sense. There's no benefit of doing it. And the quote unquote risk or nuisance is having to do the math. And if you don't have medical students, that's a nuisance. Back to Seinfeld. beyond alcohol use disorder, beyond alcohol withdrawal, which we really don't see in the episode per se. What else did you actually observe in the red dot?
I feel like George demonstrates some narcissism and, his ability, or his, willingness to try and deceive the people around him with this, like, material object, obviously, with my films, reporting it to be, in order to get the things that he wants, for it to, like, be cleanly quiet about things, about, just giving to Elaine, great favor. So it's like sort of this, low disregard for like normal honest relationships and rather manipulate.
Yeah, George in this case is a very complex character, and I've said this more than once. We can literally create an entire curriculum, and actually are currently trying to create an entire curriculum based on George. I really do think he could cover the entire DSM. I don't know about the child-adolescent chapters. Again, this didactic won't teach that anyway, just because they're usually carved out and taught by child-adolescent faculty. But otherwise, you could cover the entire DSM with George Costanza. I have no doubt about that, depending on, of course, which episode you choose. I definitely would agree that George, again, is egocentric. He has an incapacity to view a situation through any other's viewpoint, perspective but his own. There's no doubt about that. And with that comes risk. And the primary risk is developing any cluster B personality disorder. The interesting thing that I think you identified is that he actually shows a clinically significant trait defining of a cluster C personality disorder. Any guesses as to what I'm getting at? Not avoidant. Not dependent. You got one more.
CD.
Yeah. Obsessive compulsive personality disorder. What trait, what defining criterion of obsessive compulsive personality does George demonstrate? Not only in this episode, but several. Yes, but I was definitely yes. I have to give you credit for that. That wasn't the one I was looking for.
Desire for control.
Again, yes, but not one I'm looking for. The one you actually pointed out. It was the observation. Frugality. Miserly spending style. That's George. The interesting thing, though, is that there's significant overlap of OCPD traits and what many people refer to as the type A personality, right? Which is why a lot of medical students bemoan that they have OCPD, or at least traits, right? So we all do. That said, it is true that George is clinically significantly frugal. He is. He has that defining trait of OCPD, but he really is not OCPD, right? He's the direct opposite, right? He's not a perfectionist. He has no attention to detail. He's on the other end of the spectrum. If you're going to refer to OCPD as an anal retentive, i.e. Freud, he's really an anal expulsive. He's the direct opposite. So I find that a very contrasting observation with George Costanza. He definitely has not only a trait of OCPD, but one that is clinically significant, but he really does not rule in for OCPD. Matter of fact, quite opposite. A very complex character. All right, we're almost to the bottom of the hour, about 2-3 minutes to go here. What final observations do we have? We're discussing the red dot. We're good? No, we'll leave it here. All right.